So Riccardo, I'm going to hand over straight over to you. Professor Riccardo Polosa, again needing no introduction, from the University of Catalonia in Italy.
I'm still in Catalonia after 4 years. Catania. Catalonia is somewhere else. Well, knowing that I was talking after my dear friend Konstantinos, I just managed to take away at least 50% of my slides. And of course, what I did, I just kept all minds. So it's going to be kind of self-reporting my own work in the next 15 minutes or so. Of course, there's a lot of debate about the impact of long-term exposure to electronic cigarettes, and particularly lung health for obvious reasons. The way I would like to proceed with that is just to ask myself, why all these asking? What is so wrong about electronic cigarette that is causing so much concern about lung health? And I'm saying this smiling because we do have many patients in our hospitals, and they do vape a lot, and I don't see any of the problems that are being portrayed by especially scientists in Australia and in the US. And the reason is kind of simple. Simple and, it's commonsensical in a way. If you just look at the characteristic, at the chemical characteristic of tobacco compared to electronic cigarette emission vapors or aerosols, you will see immediately there are big differences. The aerosols in electronic cigarettes is far much simpler, less complex than tobacco smoke. And, if you want to talk about numbers, it's immediate that you see the number of compounds in the aerosol tobacco smoke are about 7,000, whereas in the cigarette aerosol emission are in the range of 10 to 100. And in terms of carcinogens, the difference is huge. Less than 5 for electronic cigarette and about 100 to 150 for tobacco smoke. And this is not yet, even though we find some toxicants there, those toxicants are at a level which is much less than what we see in tobacco smoke. And this is just an example. I'm not going to repeat Lionel's talk, which I liked so much, Lionel. That was great. But we do have problems. And the problem is, in the eye of the anti-vaping community, is that the use of these products is increasing. So there's a big scare. They may be dangerous. Of course, I just showed that there is some level of reduction, and the reduction is not 100%, but we also learned today that even if I quit smoke cold turkey, will not be able to achieve the 100% reduction, okay? But I'm not here to tell you that electronic cigarettes are safe. Nothing is safe in this world, not even the water you drink at home. It is much less harmful, or probably safer. So I try to understand where this concern about the long-term health effects of vaping is generated. Of course, it's generated in a number of studies which lack of some aspect of methodology. For example, in the in vitro systems and in animal studies, I still see repetition of mistakes in relation to aerosol generation and aerosol exposure. So dosimetry is not even taken into account. The generation of the aerosol is done in a way that it will generate excessive, for example, carbonyls. And this obviously will create positive signals in these in vitro systems that will make very happy researchers because they can publish their research and probably generate enough interest in the media and into the other authorities that will give grants. Even surveys are problematic. I think we, together with David Abrams, we've been scanning a number of the most recent surveys on aspects of lung health impact of vaping. And the problem is still there, you know, definitions, cross-sectional design. So because I took all those slides out, I'm not going to talk more about this. And the conclusion is that very little is known about the health impact of these products. And what do we do about this? Okay, we have a couple of questions. First question is, what is the long-term health impact of vaping under real condition of use? That's the key question. I don't care about what's happening in the lab under experimental condition. I care about what my smokers, my patients, have been exposed to in real life condition. And can we answer this question by prospective studies of very well characterized users? What do you think? Silence. Well, it's a yes or no. And I'll show you why. You can, in principle, like with the PATH study, use large prospective studies of very well characterized DC users. But there are a number of problems. They are costly, lengthy, and there are a number of issues with the health indicators that you want to use. Some are not very sensitive, some others are too sensitive. Or you can extrapolate responses to electronic cigarette in cell lines or in animal models. But as I said before, this situation does not directly apply to real-life situation. And for the surveys, I've just said the problems with working definition, problem with designs that cannot actually address the problem that we really want to address. As an alternative, we may just try to have a look and detect early changes of subclinical injury by using highly sensitive functional tests in people who we consider healthy smokers. Or we can just use what we normally use in our clinics, you know, standard and robust validated investigational tools in people with pre-existing disease. So having a pre-existing disease gives us a little edge and advantage because their baseline is not normal, is abnormal. So if there's any chance we can reverse some harm, you will see in these populations. And of course, there will be the issue of population modeling. But of course, one of the limitations of population modeling is that you have to populate the model. And it will take some time and some good quality data. Okay, let's start with the healthy smokers. What is the impact of long-term electronic cigarette use on lung function? Lung function is easy to measure. Okay, you will see immediately from this slide that at baseline, all these people who were taking part in the randomized controlled trial known as ECLAT were all within their 100% predicted of their spirometry measures, meaning that they're healthy, at least from that point of view. However, you will see that during the follow-up, there is no worsening of these parameters. Okay, I haven't shown any reversal of disease, but at least I can prove that for those who are quitting by switching to electronic cigarettes, which is the open circle, there's no real exacerbation or pejorative effect on of their lung function. However, we do have a very sensitive measure of the more peripheral airways, which goes under the number of FEF2575. You will see immediately that these people, although normal, they do have some defect in their peripheral airways. Okay? It's here. It's about 20% less of their normal predicted value. And if you select those who've been quitting smoking, they will return to normal values within 6 to 12 months. Okay? Part of these people were quitting without the use of electronic cigarette, but 50% of those were quitting with the use of electronic cigarette, and there was no difference in between the two groups. Another thing in terms of reversal in healthy smokers that you can show is by using a marker of inflammation of the airways that you can easily measure with this portable machine in the exhaled breath air. Okay? And you will see again that for the quitters, okay, all the smokers have very low level of nitric oxide for a number of reasons that I'm not going to explain to you today. But you see, if you successfully quit, you will return within the normal range. So that's really, of course, there are a number of larger studies in progress. So there'll be exciting times ahead of us. And these studies are using electronic cigarette, reduced risk products, and a number of very interesting health effect indicators, and they are long-term. Okay, what about people with pre-existing disease? To me, it seems logical to use as a clinical model an asthmatic. Why? Because asthmatics have twitchy airways, meaning their airways will respond to any trigger very easily. And in my mind, I thought, well, what happens to these people if they start inhaling these products? They should be reacting with some asthma attack. No, nothing of that happened. One of the reasons, I believe, because the vapor is warm. This is one of the reasons why they did not develop asthma attack. Ironically, if you go to the Alps and you breathe fresh breath air, cold from the Alps, you will develop an asthma attack. So it's a clear, clean, safe, but still can cause an asthma attack. And you will see over time, let me explain this to you. This part of the study, up to the second follow-up, was a retrospective. The following follow-up visit was prospective. So you will see that in terms of spirometry and force expiratory volume at first second is the hallmark of the spirometry outcomes, you will see a constant improvement over time. And the same is being shown with DFEF 2575 in this population of asthmatic smokers who switch into electronic cigarette use. Another interesting finding in asthma is to substantiate reduction in PC20. PC20 stands for the provocative concentration that is capable of causing a 20% bronchoconstriction from baseline. In simple terms, put it simply, it is a measure of the twitchiness of the airways, meaning that if I have a very small number, it takes very little of this chemical to cause 20% drop from baseline. But if I have less sensitivity in the airways, it will take a much higher concentration of that chemical to trigger the same event. And you will see what happens to these asthmatic smokers who decided to switch to vaping, that their level of sensitivity in airway hyperresponsiveness has improved immensely. We do see similar level of improvements after 6 months in health steroids. And obviously, there's also improvement in quality of life over the same period of time. And the third follow-up, which was carried out at 24 months, shows stability of the improvement. So let's change and let's evaluate a different clinical scenario. The different clinical scenario in this case is COPD. COPD is an obvious target because it's a classical smoking-related disease. And what happens with people with COPD? Okay, these people have switched to vaping, and once again here, this is a retrospective portion of the study, and this prospective portion of the study. Okay, we went up to 36 months follow-up, 3 years, and you will see here fairly clearly that there's no change in lung function, but this is not unexpected. These people have already lung function that are severely damaged and and they are poorly reversible, even to bronchodilators. This is post-bronchodilator force expiratory volume in 1 second. So post-bronchodilator, the maximal spirometry beneficial outcome that you can see in these patients. And you see there's no change over time. However, there's no detrimental effect either. I cannot see any pejorative effect in these people over 36 months continuous vaping. A very important clinical aspect which is associated with people suffering from COPD is respiratory exacerbation. And actually it's used by FDA to assess the beneficial effect of respiratory drugs in general. And you will see again here that COPD controls, which are the people who've been continuing to smoke, they are age and sex matched, they've been continuing to smoke, you will see that the level of a yearly number of respiratory exacerbation in a year is about 2.5. And there was the same starting point for those who switched to electronic cigarettes. However, you will see immediately that for these people, continuous use of electronic cigarettes being beneficial, with the number of respiratory exacerbation in a year approaching 1, which is what normally happens even if you don't do anything to these patients. I mean, even if you do use maximized therapy to these patients, because you end up having a viral infection once a year. So you do have once exacerbation a year anyway. So I would say you cannot go better than 1 respiratory exacerbation in a year. And of course, even the quality of life will improve. The physical performance will improve. But there are challenges. All I've shown today are people who were ex-smokers or were already smoking. So we know for sure that the previous smoking history and the smoking history are great and pivotal key confounders every time we want to investigate health effects indicators, even though we use sensitive indicators. So what do? The idea is to try and detect early changes using the most sensitive indicators in prospective studies of well-characterized EC users who had never smoked in their life. It's a rare breed. It's like talking on orphan disease, because Eurobarometer 2014 sets this population at 0.1%. And just to cut a long story short, because this was part of my presentation at the press conference this morning, you will see that there's absolutely no difference. Just for your information, controls are never smoker, never AC users, okay? Whereas the EC users were EC users who never smoked in their life. So you will see there's no change in all these spirometric parameters. So no impact of vaping on your lung function. And the same can be said for these inflammatory biomarkers that can be easily measured in exhale breath test. You see the level of the lower level of inflammation for exhaled nitric oxide is there, and none of these measures, with exceptions, you may have an allergic rhinitis, and you may have high levels of exhaled nitric oxide, but clearly not related to vaping. I think it's very interesting to recognize and to acknowledge that in these people at the end of the trial, which was about 3 years and a half after the start of the investigation, they also had the opportunity to have a CT scan on a high resolution. And this is a very boring picture because it shows nothing. It's a clean one. It's a clean CT scan. And I just took the one from the patient with the highest liquid consumption and the longest overall vaping history, which was 57 months. So there was no pathological findings and no evidence of COPD, which would be the most logical thing to look for, but nor lipoid pneumonia. There's been a couple of, I must say, unexisting cases of lipoid pneumonia, nor popcorn lung disease. Okay? There is diacetyl in the e-liquid used by these vapors, but there was no evidence of popcorn lung disease, and that's obvious because to develop that disease, you need high levels of exposure that you will find only in occupational settings. Last slide, so you're happy. So in my opinion, these products are unlikely to raise significant health concerns for the respiratory tract under normal condition of use. Former smokers using and smokers intending to use these products should receive correct information, and I'm saying this to the media people in the room, particularly about residual risk or potential benefits. Promoting further access to electronic cigarettes, as in this country and probably in Canada and New Zealand in the near future, may well reduce risk and reduce harm. Thank you very much.
So thank you very much. I'm sure you'll all agree with me. We've had an excellent set of presentations. Unfortunately, because some speakers ran it over, there won't be a panel discussion. So I'm afraid that's one of the consequences of going beyond your time. But these speakers are around over the lunch hour, and I encourage you to seek them out, please, and ask your questions. And can I also ask just Dr. Sharon Cox to stand up from London South Bank University? She was going to join the panel. So we'll have a few more black eyes, I think, over lunch. But again, could you please seek out Sharon so you can get her views? And just please, afternoon speakers, if you can keep to time, because I know you've got such wonderful things to say, but I'm hungry, and I'm sure the rest of you are, so we're going to have lunch. Thank you.